Hi, everyone. Good morning. My name is Peggy Hasenauer. I'm the Executive Director of the Kovler Diabetes Center. We're thrilled that you're here with us today. We are certainly welcoming those of you who are joining us this morning, and we look forward to sharing with you some insights about precision medicine and diabetes. We are offering continuing medical education credits this morning, and once the program is complete, we will ask you to complete an evaluation, and you'll receive your Category 1 credits, usually via email. And if we can answer any more questions regarding that, we will do so throughout the program. I wanted to take just a minute to thank all of our speakers today. We've collected an amazing group of experts from our team who are sharing with you today various topics on diabetes and precision medicine. Our first speaker today is our fearless leader, Dr. Phillipson. Dr. Phillipson is the Tyree Professor for Care and Research in the section of endocrinology and the Department of Medicine at the University of Chicago. He's also the director of the Kovler Diabetes Center and the founding director, I might add. And he's going to share with us today some great insights regarding precision medicine and atypical diabetes. So Dr. Phillipson, take it away.
All right, thank you very much. Let's see if I can manage to do what we need to do here. So let's see if Peggy, if you could just say you can see my screen okay?
I can see your screen. Slides look great. Yep.
Fantastic. Well, good morning, everyone. I appreciate those of you joining with us. There is a Q&A box, which I am actually looking at. So should there be a question that comes up, we can give it a shot to answer it. And in the next 24 minutes or so, I'm going to go through quite a few slides very quickly and dealing with basically three things. What is precision medicine and diabetes, or as we've been calling it, PDM, precision diabetes medicine? How does that differ from just making a diagnosis and treating patients, which many people ask me? And I'm going to then spend a few minutes on an example of all of that, which is clustering, the idea of clustering of cases of type 2 diabetes into groups as an illustration of where this concept is going for that particular kinds or those particular kinds of entities, as you'll see. And then I'm going to spend a few minutes about our study called Radiant on atypical diabetes and how that also relates to precision diabetes medicine. This will be an introduction to at least a few of the following talks. And so there's a certain amount of overlap you'll see, which is unavoidable, I think, but hopefully helpful in terms of reinforcing some of the ideas. So to get going, let's see if I can advance the slides. That's always a good thing. There we go. So I have no particular disclosures today about the content of this talk. So what is precision medicine in diabetes? So the idea here is that some of the folks I've been working with on this in the last couple of years, and I'll explain that in a moment, have a variety of definitions. And so one of them is an emerging approach for disease treatment and prevention that takes into account all sorts of different kinds of individual variability, really sort of everything you can think of: genes, environment, lifestyle, anything else that might go into the particular evolution of a disease state in that particular patient. And this is now an evolving concept, of course, for cancer, for cardiometabolic disease, and almost every aspect of medicine. The idea that this is a global overview that takes into account all of these things is the underlying feature of this. How this might get translated into clinical practice is the main problem. So the group that I've been involved with is the American Diabetes Association EASD, European Association for the Study of Diabetes Task Force, which is not limited to those groups. In fact, we have representation now from groups all over the world. The Executive Oversight Committee has evolved some. It includes Paul Franks from Lund and Copenhagen, Steve Rich, University of Virginia, as the two founding members. One of the original leaders of this organization, as it were, is Will Cephalou, who left the ADA to become head of the diabetes branch of the NIDDK. So Will continues to be very interested. We have John Nolan in Dublin, Bob Eckel in Denver, a past ADA president as well. And Bob Gabay continues to have this close to his heart as now the CSMO of the ADA. And you can see members of the steering committee there, some of whom I will mention as we go along. This was the first major paper from our group. It came out last year, and some of the folks you can see there, Wendy Chung at Columbia is the lead author. Some of these people I will also talk about in a moment, with support, as you see there, from including the NIDDK and the JDRF. So the question becomes, what do these terms mean? And many people use precision and personalized terms interchangeably, but they are definitely separate or separable. So the idea of precision in this definition that Paul Franks came up with, and from one dictionary, is the quality, condition, or a fact of being exact and accurate. Now, the example there of military precision may in fact be an oxymoron, but that's the idea. Whereas personalized is the tailoring of a program to meet someone's individual requirements. So exactness versus individual, that's how we're seeing this. So in this case, the idea is that we have precision medicine. It's also been called stratified, tailoring diagnostics, therapeutics, prevention, treatment to subgroups, minimizing error and maximizing efficacy. On the other hand, personalized could be thought of as the final step. So this is where the individual patient's characteristics, including housing, food security, financial stability, all of those things, in addition to what we traditionally think of as pathophysiological features, are taken into account. This is a diagram in one of the now early papers, a classic work all the way back in 2018 from Therapeutics and others who put this figure together. And basically it was the idea is, what could be a roadmap here, where we start with perhaps a better understanding of disease, risk factors, some vertical integration, disease-specific biomarkers, which we're still, of course, deeply involved in understanding. What are some of the endpoints? What can we do in diabetes as biomarkers? We'll come back to that in type 2 diabetes, regulatory engagement, and things like health economic assessment, HEA, but then also feedback of people with, in this case, people with diabetes. What does it mean to them to be treated with disease? What are their preferences and so on? So those are some of the things that we are looking at. So this path includes genetics, but some people have been concerned that it's all about genetics. And I would say that genetics plays a role, but at the end of the day, for most kinds of type 2 diabetes, genetics will only be informative and not the main thing, if it's informative at all. So this is the concept in cartoon fashion. Rather than one size fits all, we have this notion that stratified approaches might be better. In this case, grouping folks into whether they might be responders with or without side effects, for example, or non-responders to a particular therapy. And if we wanted to maximize health, the idea is, can we group these folks into these different groups for specific treatments? So these are some of the areas that we've as a group focused on. Now, these are 5 areas: diagnostics, prevention, treatment, prognostics, and monitoring. There could be 1 or 2 additional areas, but this is where we started out with in some of the original group discussions. And is a couple of examples. Here is a more detailed dive down into what precision diagnostics might mean, that we have both an epidemiological evaluation, so the group that the particular person at risk or with the disease is in, how does that make sense in terms of perhaps understanding their trajectory, probability based on clinical features, and I'll go into this a little bit more, and we talk about sort of complicated things versus simple clinical measures that could be very useful, and then specific diagnostic testing, which may vary. And part of the concept here is we're very sensitive to a worldwide application of these sorts of ideas. What constitutes something that we could do, say, in India or Africa or Asia, other parts of Asia, that might not be applicable to, say, the United States or Europe, or vice versa. And then the idea of probability scores based on some of these measures and sub-classification. And how does all this get communicated to the physician who has roughly 8 to 12 minutes to see a patient? And these are some of the other things that we're putting into this concept of precision prevention, precision therapeutics, which would be, so both of those things are subcategories where treatment would be monitored in terms of efficacy, but also minimizing side effects, and how that might then interface with lifestyle interventions and avoidance of further risk factors. I mean, this is a slide that we've seen, those of us who treat people with diabetes, many times, but it does get at one aspect of what precision therapeutics includes. For example, in the case of the liver, Dr. Thomas is going to go into that in much more detail. And this slide, in fact, is old. She'll be talking about, much more modern approaches than metformin and insulin to liver disease in general. But otherwise, we have this sort of very formidable approach at the moment to targeting underlying defects in diabetes. The question is, how do we rationalize them? And what tests can we make to make this more of a useful category without, say, an algorithm that's one size fits all, starting with metformin, which I think is we're rapidly realizing that it's not going to do the job. Prognostics, on the other hand, is how can we work together with groups and individual patients to help understand what is the long-term trajectory. We're worried a lot about cardiovascular disease right now, but clearly nephropathy, neuropathy, retinopathy are all the things, part of all the things that we are concerned about. How do we know? Are there ways to know the trajectory of someone using, basically a four-dimensional analysis? So we have the time, which will have to get factored into the EHR in order to come up with some way to help busy clinicians understand what they can think about and how they can minimize those outcomes. Now, I want to spend a couple of minutes on the newer ideas about clustering in type 2 diabetes. So beginning with several papers, including this contribution from Dr. Group's group in Sweden, which includes many well-known Scandinavian investigators. This paper from a few years ago was one of the several papers that led off the idea that there are subgroups of adult onset diabetes. Now, we knew that. I mean, not everyone with type 2 diabetes is the same. There are people who are with obesity or not with obesity, but using this cluster analysis, they were able to define people. And it's very important to understand that this was at diagnosis. So once years have gone by, there's a certain amount of fluidity in different groups. And I'll go into this in more detail for a few slides. After that analysis, Miri Mudler and Jose Flores at Mass General have made now a series of contributions trying to see how genetics might inform this sort of clustering analysis. So now there's a back and forth between simple clinical measures, what happens at diagnosis, how the different clusters evolve, and whether genetics can help. So what has been fascinating is that the genetics clustering corresponds reasonably well to the clinical measures clustering, which includes two groups in this case that had to do with beta cell problems. So insulin secretion by itself, a pro-insulin biosynthesis, and then groups related to specific characteristics of obesity, lipodystrophy, and a liver lipid group. So these all had interesting aspects of characteristics originally, as well as prognosis. So what we can talk about here are how these areas relate to simple clinical measures. So in this work from the Hattersley group, Dr. Hattersley at Exeter has been very interested in the idea that we're already doing a lot of what's necessary. We can use simple clinical measures to understand where this clustering may be very helpful. And so what he said in this paper and what their group said is that this idea of precision diabetes medicine in type 2 diabetes is likely to have clinical utility if it's based on an approach of specific phenotypic measures. So trying to establish these sorts of things. And here he was very simple. It was gender, BMI, age diagnosis, baseline A1C, as well as creatinine. And this is then picked up in other countries. This is a similar cluster analysis by, it happens, some colleagues of ours in Bangalore, Dr. Aravind in particular. And in this paper, which just recently came out, they tried to use a simple set of clinical variables in a population of about 18,000 patients, I believe, looking here at not only age and BMI, but waist circumference, which I recall John Buse in North Carolina mentioning as a key factor maybe 20, 25 years ago in a grand rounds he gave here. A1C, triglycerides, HDL. And from these, they were able to get replicable clusters, which I'll define in a moment. And these are those clusters which roughly correspond to the other groups. A kind of type 2 diabetes, which is severe insulin deficient, which in some cases now overlaps with adult onset type 1, severe insulin resistant diabetes, mild obesity related diabetes. So this is mild diabetes. So in other words, not difficult to treat with high doses of insulin, although the definitions I think are still in progress. In this case, high HDL, otherwise not having extreme characteristics. So they defined it as mild. Insulin-resistant obese diabetes, and then combined insulin-resistant and deficient diabetes. And in retrospect, I think many of us see cases like this all the time. Another subsequent paper, which just came out in the last few months, is a European study. This is called the IMI Rhapsody study with Dr. Pearson in Scotland leading this one, but also many of these groups are overlapping. And what they also looked at were these clusters of severe insulin deficient diabetes, resistant diabetes, mild obesity-related diabetes. Doesn't mean mild obesity, but mild diabetes is how that's defined. And so the idea is, how do these cross clusters hold up in the different studies? And the answer is reasonably well. But what is interesting is that there is some fluidity. So if you follow folks over time, or you don't see them from the very beginning, you can get a different answer as to what sort of group people might belong to. And with treatment, sometimes there are changes from more severe forms to less severe forms. So why do this? So as I've tried to indicate, that clustering might help, and it might help by not only classification, but what is the implication of classification? So can you plan therapies? If someone is immediately recognized as a severe insulin deficient sort of person, then metformin, for example, might not be your first approach. But how do we do this? And how do we get these sorts of clusters to both treat specifically, prevent complications, and further enhance our approach? So if we compare some of these attempts at clustering from the recent papers from Exeter versus the recent paper from South India, there's much overlap here. What was different actually in India was that they went ahead and used fasting and stimulated C-peptide as part of the classification, which is not part of our traditional routine clinical measures, at least in the United States. So I think these things are a work in progress. And you can see the other European study using age, A1C, HDL cholesterol, BMI, and also C-peptide, all of which are complicated and flawed when you get down to it, except perhaps age. But those are some of the measures that we have right now. So to summarize this part of the talk, and I'll just have a few more slides, we think, and this is the guideline now of really hundreds of people around the world who are working in this area, that precision diabetes medicine can guide diagnosis, treatment, and predict outcomes, that genetics may be important in developing risk scores, but as you'll hear from Dr. Naylor in a few minutes, and I'll just mention this briefly, various sorts of monogenic diabetes and atypical diabetes is likely to inform this whole program going forward. One hypothesis is that precision diabetes medicine is in fact cost-effective because it targets therapies so well, but in fact, this remains to be shown. And then, can we use simple clinical measures to guide this strategy in a way that's time and cost-effective? So these are things that remain to be seen. As an introduction to Dr. Naylor's talk, just to remind you that, and now we're going to talk about atypical diabetes a little bit, we really, for many years, focused on type 1 diabetes as an autoimmune form, which we had thought about mostly in children, but in fact, also half of which shows up in young and older adults. The complicated aspect of type 2 diabetes, which I tried to show you, in which I often quote Sir Edwin Gale as telling somebody they have type 2 diabetes is equivalent to telling them nothing at all in terms of how we understand pathophysiology. But then we have a growing interest, and certainly in our group, in atypical forms, where monogenic diabetes, as you'll hear from Dr. Naylor, represents several percent of all diabetes, which appears, say, in children or in young adults. And then we have some additional forms of diabetes which remain atypical and undefined. So I wanted to talk a little bit about our study called RADIANT, which is now in its well into its third year, almost the fourth year. This is a study that came out of an RFA from the NIDDK that now is a multi-center study, which involves identifying, if we can, new forms of unusual kinds of diabetes. Some of this grew out of a publication of a book that I helped write with Dr. Drazen and Janet in Colorado and Janet McGill in St. Louis. So the background of the RADIANT study is that we really started recruiting just about a year ago. We're going to have this first period end in two more years, 2.5 more years. There's 2 grants that have been identified, that have been awarded, one to us here in Chicago, the other to Baylor College with Dr. Balasubramaniam. Jeff Krischer in Florida is the chair. The steering committee includes Jose Flores of the Mass General, and at the NIH and NIDDK, Christine Lee and Ellen Leshik. There are 14 centers across the United States that are involved in recruiting, and genomic centers at Baylor and the Broad. So what does this look like? And I pictured here Lisa Letourneau, who's part of our effort here, who's really been the heart and soul of this program. And you can see that the idea of this is discovery. So we want to be able to identify those forms of diabetes where a patient or a person with diabetes may come to you and what your answer is as the clinician is, gee, I don't understand why this person has diabetes, or there's something else interesting about their particular form. So how can we do not only discovery, but how can that lead to smarter testing and a more accurate diagnosis? And this is where we have been publicizing the study to people with diabetes. If you've been diagnosed, but your doctor says, gee, I don't know what you have, or you have many diagnoses, or you move from one to the other, perhaps this is something we ought to look into. These are where the sites are around the country. And you can see Chicago, and for sort of various historical reasons, they're clustered in the eastern part of the United States, but we're hoping in the next incarnation of the study to include more centers evenly distributed around the country. How do you get into RADIANT? Well, if you have a high likelihood of rare or atypical forms of diabetes, specifically maybe non-obese, but not only, because there could be lipodystrophies here that we need to understand. If they're syndromic, in other words, diabetes plus other sorts of organ or systemic involvements, where could be low insulin requirements, could be dramatically high insulin requirements, could be very lean, and usually antibody negative. So we're ruling out from this particular study autoimmune causes of diabetes. And that's what you can see on the exclusion criteria. And whatever typical type 2 diabetes is, which might be later onset and associated with some aspect of obesity. So that continues to be a work in progress, but because genetic testing is critical, and part of this program is in fact whole genome sequencing, refusal of genetic testing is exclusionary. So this is the flow diagram for the study based on initial entry with consent and managing the process by looking at presence of antibodies, even at the time of entry. Obviously, it would be better if we could do antibodies, anti-islet antibodies at the time of diagnosis, but oftentimes that's not there. Then there's a second consent form. Once a variety of forms and histories are evaluated, there's an adjudication committee, which helps understand whether a particular person, a participant, should continue. And then stage 3 will be a series of phenotypic studies, which are still also a work in progress. As of yesterday, this is where we are in this study. We have over 600 folks recruited and working through the various studies to collect specimens. It's getting a little bit exciting. We have now the first set of genetic data, which is coming in. What's interesting also is about 20% of all of these folks seem to be antibody positive, meaning that they really did have type 1 diabetes, and that was not understood as a possible cause of their diabetes. So this could be something that comes out of the study that's very important, that we may need to have antibody testing in diabetes as routine if we're missing it to this extent. So I'll end with this slide. We are learning a lot from monogenic diabetes, and Dr. Naylor will go through this in much more detail. But if there is anything to take home, is that we want to consider a phenotype-genotype connection in all forms of diabetes. A family history is sometimes incredibly helpful to understand if there's something linking these things. It could be environment, it could be genetic, but we need to understand that diabetes is a disease that can affect the entire family. So these are some of the groups that are involved. Our group here in Chicago, we've had an enduring relationship with the group of Dr. Hattersley at Exeter Peninsula University, some of our colleagues, Susumu Seno, who recently passed away, and some of our funding sources. So of all the people to thank, of course, I want to thank many of the participants in our various research studies who have really allowed us to reach this point and continue these studies. So I'm going to stop there, and we'll see if there are any questions.
Fantastic. Dr. Phillipson, there was one question in the Q&A regarding mid-obesity, and it's possible for you to answer that now, or you can go ahead and answer it on the Q&A. So they wanted sort of a general understanding of mid-obesity in that 28, 30, 32 BMI range, which
right. Well, so it's an interesting, I just take a minute now. I mean, I
sure.
think, part of this idea of obesity has to be centered in the ethnic and racial background of that person. I had a conversation with a patient yesterday who is even of European ancestry, but his mother is an endocrinologist. And so while he's 6'2" and 195 pounds with a BMI of 25, his mother tells him that he's overweight and his BMI needs to be 23. And then we have people from, say, South India, whose ideal BMI in many cases might be 19 or 20. So mid-diabetes, mid-obesity or mild obesity really is contextual, and that's, I think, the point. The idea, though, in some of those studies was that the diabetes was mild, and that didn't necessarily have to be treated with high-dose insulin. So that's one of the things I wanted to get at.
Oh, I appreciate that. Thank you. And thank you, everyone, for joining us today. And please continue to go ahead and put your information in the chat. I want to continue on with our program today. Rochelle Naylor, Dr. Naylor is with us now. She'll be talking to us and sharing more on the topic of atypical diabetes. Dr. Naylor is a pediatric endocrinologist by trade and does tremendous research in atypical diabetes, but specifically in MODY, and understanding barriers to being tested, and also understanding how we can define MODY for various populations and include them in testing and the registry. So Dr. Naylor, thank you for joining us. And those of you who want to ask questions, please put them in the Q&A. Thank you.
Sorry, working on sharing and unmuting. All right, people can see my slides and hear me.
Yes.
All right, wonderful. Well, good morning, all. I'm thankful to have this opportunity to speak to you today on monogenic diabetes and show you how it is an exemplar of precision medicine. I have no financial disclosures. So we'll start with the scope of diabetes. Diabetes affects over 30 million people in the US at a cost of more than $327 billion. And despite this expense, many people are not achieving their glycemic targets. This is partly explained by the fact that diabetes mellitus is not one disease, but many. And the heterogeneity in the cause of diabetes can make prescribing the right treatment and giving the right management guidance difficult. There is a thought that if we can better classify why someone has diabetes, then we can apply precision medicine. And precision medicine in turn holds the promise to improve outcomes. The concept is that we take the heterogeneity And we find characteristics where we can better subclassify or cluster people. And that clustering or that subclassification, the more refined it can be, the better able we can tell a patient, okay, this is how you could prevent diabetes, or this is the management that you should be on for your diabetes treatment. And then we can go on and personalize it in terms of dose and regimen, et cetera. And as Dr. Phillipson has already covered, this is the whole concept behind the Precision Medicine and Diabetes Initiative of the ADA, ASD, and other organizations. And the thought is that people with diabetes will have longer, healthier lives if we can apply the appropriate treatment for the appropriate person at the appropriate time. And in the consensus report from this organization, they identified monogenic diabetes as one of few areas where precision diabetes medicine has been proven feasible and is practiced. And so we're going to turn our attention to monogenic diabetes and spend a lot of the time on MODY, specifically maturity onset diabetes of the young, to think about how we can apply precision medicine in diabetes. Monogenic diabetes represents up to 3.5% of all diabetes diagnosed under 30 years of age, and it comes in two main flavors. There's neonatal diabetes, which is typically diagnosed under 6 months of age. And then there is maturity onset diabetes of the young, or MODY, which is an autosomal dominant young onset diabetes, typically coming on in adolescence or early adulthood. We are going to use this figure from the consensus report from the Precision Medicine Diabetes Initiative to describe how MODY serves as an exemplar of precision medicine. So precision medicine really starts with precision diagnostics. We classify to as precise a level as possible the type of diabetes somebody has. And that allows us to then, again, optimize their treatment recommendations and prognostication. And so all of this starts with epidemiologic evaluation, where you, based on the prevalence of the subtypes of diabetes that we are able to classify, we say, what is this person likely to have? We further refine this based on additional clinical features, laboratory tests that we do, and then we can get down to diagnostic testing to really try to classify them as best as we can. And again, we're going to focus on how we can do this and classify them with various forms of monogenic diabetes. So to really look at this epidemiologic evaluation and the clinical features, when we think specifically of MODY compared to the prevalent polygenic forms of diabetes that are imperfectly captured in the terms type 1 and type 2 diabetes, we can think of the age of onset as guiding us, right? We expect that if someone is young, they are more likely to have either type 1 diabetes or a monogenic form. We are not expecting to see positive beta cell antibodies. We're not expecting to see ketoacidosis in the monogenic forms of diabetes because these are not attributed to complete beta cell destruction as we see in type 1 diabetes. There are other biomarkers that we are able to use to select people who are likely to have these monogenic forms of diabetes and then go on to additional evaluation to get to the diagnosis. This algorithm maps out the process for monogenic diabetes, again, starting with epidemiologic evaluation and specifically really age, right? So under 6 months of age, absolutely, this individual is likely to have a genetic form of diabetes and should be tested for the neonatal diabetes genes. If they have features such as deafness or neurologic features, we should be thinking about the mitochondrial diabetes causes. And then if they don't have these features, then we start to think between type 1, type 2, and MODY. If they are non-obese, if they have their endogenous insulin production beyond 3 to 5 years of diagnosis, if there's a strong family history, not the type that we see in type 2 diabetes, where we often feel like everybody in the family has diabetes, but rather that pattern that comes when you have a 50% chance of inheriting a gene, then we think of MODY testing. And this study from the UK group shows what such an approach can yield. And there's been several others, including in the US, that shows what we can use, how we can achieve diagnosing monogenic diabetes and then go on to precision medicine treatment using this sort of epidemiologic analysis and biomarker screening to select who should get the genetic testing for monogenic diabetes. So in this study, They started with a population under 30 and basically went through the process of proving that they had endogenous insulin production and did not have antibodies that would be suggestive of type 1 diabetes, and then went on to do genetic testing. And they started with more than 2,000 patients, but you see that by the time they apply this algorithm of the epidemiology, the clinical features, and incorporated biomarkers, they got down to about 10% of the patients who would be even looking at for genetic testing, and ultimately were able to diagnose 51 cases of monogenic diabetes. 34 were actually already known, but picked up through this algorithm. And what they showed is that with this biomarker pathway approach, you need to test 5 people to diagnose a case of monogenic diabetes, but you're essentially missing no cases. Now that's not entirely true because they weren't looking at mitochondrial diabetes, et cetera, but you're going to pick up the majority of diabetes because MODY makes up the bulk of diabetes causes of monogenic diabetes. There's the traditional MODY criteria. We say young onset, usually under 25, a parent affected, non-obese. You only need to test 2 people, but you're missing a ton of people who could get a genetic diagnosis and have that impact their therapy. There's also a MODY probability calculator that's widely available. It's an app from the UK group. And this also helps you to identify patients who should be tested, but again, misses a lot of people. So this instead applying this systematic approach, looking at the epidemiology, the clinical features, and applying biomarkers, get you to the person who you need to test. And I want to make sure before we go on to talk specifically about the precision therapeutics, to let you know that doing this methodical approach and finding people to test is cost effective. When you have somebody who has a high probability of having MODY because of the treatment changes that come and the improvement that they see based on those treatment changes, it is cost effective to do the genetic testing because of the money that's saved by changing their therapy and by decreasing their likelihood of complications. And this was work that was done by Dr. Goodsmith, who was at the time a Pritzker medical student at the University of Chicago and now is a medicine pediatrics resident, myself and Dr. Wong and Reza Skandari. And so we showed that if you did the biomarker screening, that it was actually not just cost effective, actually saved money. And that, of course, if you then go on and correct the diagnosis in family members in this autosomal dominant disease, you're saving even more money for the healthcare system. And so now we're going to turn our attention to the back to the precision diagnostics before we go to precision therapeutics. So once we've identified people who are likely to have MODY, it allows us to go on to diagnostic testing. In this case, that is genetic sequencing, right? We do gene testing to make this diagnosis. And it is important that you do gene testing. There are a lot of people who look like they may have MODY, and when you get the testing done, they do not. And so you should not take the therapies that I'm going to discuss for the common causes of MODY and apply them to a patient without understanding what they really have. So it's not good enough to make the clinical diagnosis. You do need to get the genetic diagnosis. Once you do that, you're able to classify them. And what we're going to cover in the last moments of this talk is the management for the most common and clinically actionable forms of MODY. But before we do, I have to say a few words on ordering genetic testing because I've just told you it's so imperative that you do so, but it's also imperative that you do it correctly. And so number one, use a CLIA certified lab. So there are often academic-based labs. There may be labs right in the hospital or organization that you are affiliated with. For instance, at the University of Chicago, we have our own genetic services lab, but there's also lots of commercial labs. The list is too long for me to name, but there are plenty of options out there for commercial labs. And so oftentimes you actually will go with whatever the insurance tells you they're willing to cover. It is very important that you get a prior authorization before you order genetic testing, and you need to be mindful of copay. Some people, their insurance company will cover the genetic testing, but because it may be several thousands of dollars, depending on their copay, that still may be untenable for them. And so you want to keep that in mind. A lot of these programs do have payment plans or assistance plans for patients if they're paying out of pocket that really limit the cost that they're going to have to spend. Again, that's still untenable for some. And so you can then look to research-based testing, such as what we do out of the Monogenic Diabetes Registry housed at the University of Chicago. But again, first try through the insurance to get the CLIA certified clinical diagnosis. And then please, 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 if you're at all uncertain about the genetic testing report, does this patient have MODY? They found a variant. Is this the cause of their diabetes? Make sure you get help. We have seen in our registry people getting diagnosed with monogenic diabetes based off of a variant that actually is not pathogenic. So we know that we all have variants in lots of genes, and it's not affecting us for the most part. And so even having a variant in a gene that's known to cause MODY doesn't in fact mean that the patient in front of you has MODY, or at least not for that cause. So again, get help. And I will put our information right here from the Monogenic Diabetes Registry, our email, as well as our website if you need any assistance with any portion of this process. Okay, so let's talk now about precision therapeutics for MODY, because this is really what we are trying to do, right? Get from precision diagnostics so that we can direct what we tell the patient to do, what we prescribe for them, how we manage their diabetes. And for this last part, we're going to use a couple of cases to discuss the 3 common and clinically actionable forms of MODY, starting with precision medicine for GCK MODY. So imagine you have a 32-year-old male who knows he has a diagnosis of GCK MODY. He's actually coming for a second opinion for his diabetes management. He was initially diagnosed with type 1 diabetes when he had a fasting blood glucose of 128 milligrams per deciliter on a work physical, had a subsequent follow-up hemoglobin A1C, which was elevated to 6.6%. And so that made a diagnosis of diabetes. And he started on an insulin pump almost immediately, and he's been doing just fine on it. His fasting blood sugars are ranging in the 110s to 120s, and his hemoglobin A1C has ranged from 6.4 to 6.6%. But his sister also was recently diagnosed with GCK MODY, and her doctor said, oh, well, now you don't need to be on any treatment at all. So he's come to you to say, well, then can I stop my insulin pump? And so the question here is, what is the appropriate management of GCK MODY? So a few words first. GCK MODY, so GCK encodes the glucokinase enzyme, which catalyzes the first step in glucose metabolism. So it essentially is our glucose sensor. It links increases to our glucose to insulin secretion from our beta cell. And if you carry a heterozygous inactivating mutation in GCK, then the set point for glucose-stimulated insulin release is raised. And what this results in is a phenotype of stable, mild fasting hyperglycemia and an A1C that typically is in the range from 5.6% to as high as 7.6 to 7.8% for individuals with GCK MODY, but typically that one that doesn't move a ton for the individual person. So often if a person's A1C is typically 7.2%, they live around that range. This graph is showing the unaffected relatives of individuals with GCK MODY. It is showing their A1Cs across age, and what you see is this age-related deterioration in glycemia that we all fall victim to. And then you see here, this nearly superimposable but higher line, upward shifted, are those people with GCK mutations who, again, have otherwise normal beta cell function and everything in glucose metabolism, but the thing that is different is their set point for insulin, glucose-stimulated insulin release. Because everything else is functioning appropriately, what we find is that the microvascular and macrovascular complications that we're so worried about in type 1 diabetes and other forms of type 2 diabetes and other forms of monogenic diabetes don't occur in GCK MODY. And so what this graph is showing is macrovascular complications in, microvascular complications in green and macrovascular complications in yellow, as well as these combined. And so this is GCK, this is their unaffected relatives, and these are people with type 2 diabetes. And what you can see is that those with GCK have really no difference in their macrovascular outcomes. You might even want to say that they have less than their unaffected relatives, but this study wasn't powered to say that there was really a difference there, but they certainly don't have a difference between the prevalence of macrovascular complications. And for the tiny bit of microvascular complications that these individuals with GCK MODY had, it was all background retinopathy with none of it needing therapy. And the average age of this group was 50 years of age. And so that means they had been exposed for 50 years to mild hyperglycemia, and this was the outcome. And so to get back to our patient and his question about being able to stop his insulin pump in light of his sister being told she needs nothing, is that his sister's doctor was absolutely right. Precision medicine for GCK Modi is no medicine at all, with the caveat that I'm talking only in the instance of outside of pregnancy. And later, Dr. Dickens will discuss the appropriate management of GCK Modi in pregnancy. This cross-sectional study shows what happens to A1C in individuals who were initially on oral hypoglycemic agents or insulin before their diagnosis, the white bar showing their A1C completely unchanged after all medications were stopped, because they don't need it, and it's actually really hard to affect the glycemia of people with GCK Modi because their insulin, their set point is genetically defined. So if you give them insulin, they're just going to turn off their own endogenous insulin. So it's actually quite hard to impact their glycemia unless you're kind of, giving quite large doses of insulin. All right. We're going to have a second case to talk about precision medicine for HNF1 alpha Modi, and we'll really talk about HNF4 alpha Modi as well, because HNF1 alpha and 4 alpha Modi are quite similar, although they do have some distinct features between the two of them. So now you have a 25-year-old female in your clinic, again, with a recent diagnosis of HNF1 alpha Modi, and she was started on glyburide 5 milligrams daily following genetic diagnosis. And since then, she's had multiple episodes of hypoglycemia, but when she has tried to skip the glyburide, she notes that her blood sugars are above goal and wants to know what she should do next. So we'll look at what management options we could consider for her. So for a little bit of background, HNF1 alpha Modi and 4 alpha Modi are the first most common and the third most common cause of Modi, together with GCK representing about 80 to 95% of the Modi that we see. Both result in a progressive defect in glucose-dependent insulin secretion. So you get young onset diabetes, and it does come with all the microvascular and macrovascular complications that we think of in diabetes tied to glycemic control. So good glycemic control is really important. It turns out that this cartoon of the beta cell is showing all of the number of things that get impaired when you have mutations in the HNF1 alpha and HNF4 alpha gene. And you can see that you are actually impairing a number of things, including glucose metabolism and insulin secretion. But as it turns out, you can bypass a lot of what is wrong by using sulfonylureas or meglitinides, which are basically the weaker cousins of sulfonylureas, binding to this receptor here. So people with 1 alpha and 4 alpha are actually quite sensitive to sulfonylureas, so much so that we are typically starting with a quarter to a half a tab in someone who is treatment naive or been very recently diagnosed, particularly if they are young and normal weight. And then you titrate up as needed. There are times that actually even that is too strong, and so we'll turn to our meglitinides as an alternative treatment option if hypoglycemia is a problem. And so for the patient in front of us, she needs a lower dose of glyburide or potentially even meglitinide. And what we know is that when you transition from insulin to sulfonylureas, oftentimes you see a decrement in the hemoglobin A1C as much as 1.5%. And a dedicated tertiary Modi clinic in Ireland has shown that this results in much lower complication rates in modern HNF1 alpha Modi, where there's not a significant delay in the diagnosis versus historical cohorts. And in this study, you can see this change in hemoglobin A1C in people who were able to successfully transfer to sulfonylureas. Now, the durability is not perfect, and the one clear risk factor is weight gain. So in all of these people in follow-up of about 7 years, average follow-up time, weight gain was the common factor that made people need to add therapy. But luckily, we actually have had a number of studies showing the efficacy of the GLP-1 receptor agonists or even the DPP-4 inhibitors as an augmentative or even alternative therapy for HNF1 alpha or 4 alpha. And so I would like to wrap up by reminding you that precision medicine in diabetes can help people with diabetes have longer, healthier lives, but correct classification is a critical first step in precision medicine. And hopefully with these cases, I've showed you that monogenic diabetes is an exemplar of precision medicine. And we hope that we will be able to achieve this same ability to really impact somebody's treatment and improve their diabetes outcome, and often significantly decrease the burden of their diabetes care by applying these sort of principles to what is, again, imperfectly captured by categories of type 1 and type 2 diabetes. Specific MODI take-home points: always consider MODI in young onset diabetes, confirm with genetic testing, and always get a PA, and always get help interpreting the results if there's any uncertainty. And then once you've confirmed the diagnosis, do implement precision therapy. Sulfonylureas or meglitinides for 1-alpha and 4-alpha, and then no pharmacologic therapy and de-escalation of diabetes care in GCK MODI. And with that, I'll end by thanking you for your attention. I'll leave my email here if there's any way that I can be helpful. And I will also leave, again, our website for the Monogenic Diabetes Registry, our email, and I will remind you, for people who looked like they could have had MODI, but their genetic testing proved otherwise, make sure to refer them to the RADIANT study. Thank you.
Thank you so much, Dr. Naylor. I truly appreciate it. If anyone has any questions, please put them in the Q&A. We don't have any questions at this time, but if you do have questions for Dr. Naylor, we certainly will share those and discuss those. I wanted to, again, thank Dr. Naylor and Dr. Phillipson. We will now move on to Dr. Raghu Mamira. Dr. Mamira joined the University of Chicago about a year ago, but he's been a longtime friend and alum of UChicago. He is a professor in endocrinology in the Department of Medicine, and he will be talking to us today about new thoughts and new ideas on beta cells in type 1 diabetes. So Dr. Mamira, I see your slides. Thank you so much, and take it away.
Thank you so much, Peggy. Really delighted today to talk about something that's really my passion, both on the research side and the clinical side, and that's type 1 diabetes. And this particular forum on precision medicine, I think, is particularly appropriate now, because we've begun to recognize that type 1 diabetes really is a very, very heterogeneous disease. And I think it's caused us to rethink how the disease develops and how we might treat it. So I just wanted to show my disclosures. And this is, of course, a very special year. This is now the 100th anniversary of the discovery of insulin by Banting and Best in 1921. I also like to point out that, just 1 year later after the discovery, the first person to receive insulin in North America was James Havens. And his father wrote at the time when he received this extract that Banting and Best identified, whether it is possible that nature will restore the diseased pancreas when the strain is taken off of it by administering this extract, and while other functions of the body and bodily strength is restored, is merely a hope. It may be possible. Well, what we've learned, of course, since that time is that insulin is not a cure for type 1 diabetes. In fact, it's not a cure for any form of diabetes. It is a treatment. And what we have learned in the years since 1922 is that type 1 diabetes really is a disease of the pancreatic islets. And what we now know is that the loss of beta cells within the pancreatic islet is really the hallmark of type 1 diabetes. So this was a classic diagram of beta cell mass that was depicted by George Eisenbarth in the late 80s and early 90s. And it shows what we understood and still, for the most part, understand today about the pathogenesis of type 1 diabetes, namely that there is genetic predisposition, but clearly that isn't enough. There seems to be an environmental trigger, which we haven't clearly defined yet, but we know that there is an environmental trigger at some level that then triggers an autoimmune process in which we can detect multiple autoantibodies at some point. And then subsequently, there is a loss in beta cell mass. And at some point, as beta cell mass is lost, we get into phases of diabetes, including pre-diabetes, where there's what we would call dysglycemia or elevated glucose. And then the thinking has always been that when you've lost about 90% or so of beta cell mass, you develop clinical type 1 diabetes. And in the classic sense, this picture is how we viewed type 1 diabetes for many, many decades. And this is a picture of a pancreatic islet stained for insulin in red. And then what you could see, the blue mononuclear cells are the invading immune cells. And you could see them in this image literally chewing up the pancreatic islet. And this is the way we've sort of imagined type 1 diabetes to be. And that is that there is this relentless autoimmune attack on beta cells, and that subsequently the beta cells eventually are extinguished and you develop disease. And so we had thought for many, many years that it is really an autoimmune disorder, and therefore it's a dialogue between the different types of immune cells in the body, and that these immune cells communicate with one another, and that ultimately they attack the beta cell. But what we've begun to realize in the last decade or so is that it's more than just that, that the beta cells are not a bystander that just succumbs to the immune system, but that the beta cells themselves may be an active participant in this disease, whether they initiate the disease or whether they exacerbate the disease. And we'll talk a little bit about that today. But more importantly, that there could be really a gradient, if you think about it, depending on the individual, where there might be more of a shift to autoimmunity versus more of a shift to beta cells as the underlying cause of the disease. And we'll talk about how we've come to those conclusions. So over the past couple of decades now, the mainstay of clinical studies have been focused on agents that target the immune system. So agents that target T cells, B cells, memory T cells, co-stimulatory molecules have all shown variable success. And as you could see in these images here, this is if you would take the y-axis as being some measure of beta cell mass. This would look a lot like that Eisenbarth diagram I showed you, where there is loss of beta cell mass or insulin secretion, and that any of these therapies certainly delay that loss. But what you could see is that after ongoing therapy, there is ongoing loss of beta cell mass at a slower, at a more delayed time frame, but at roughly the same rate, there is loss of mass. So very clearly, initiating therapies at very early onset diabetes targeted towards the immune system doesn't appear to be sufficient to at least halt the progression of disease. More recently, a very exciting study came out. Instead of taking individuals with new onset diabetes, this study targeted individuals who were at risk for type 1 diabetes. And so these were typically individuals who were first-degree relatives and who had multiple autoantibodies. And you could see here when anti-CD3 was given to these individuals, teplizumab, that there was roughly a 2-year delay in the development of type 1 diabetes in these individuals. So this is actually pretty exciting data. And but it does cause us to think still that what's happened here is really just a delay in disease and not the kind of prevention that we had hoped to achieve with drugs that target entirely the immune system. So, and one can conceive that there are probably some individuals who benefited more from this therapy than others who benefited less. So for the past several years now, we've been kind of rethinking the pathogenesis of the disease and introducing a new concept called the endotype concept. And this largely came from studies of asthma, where people believe that asthma is more than just an inflammatory disease, but that there are different pathogeneses depending upon an individual. And we've been coming to the conclusion that type 1 diabetes may in fact be a heterogeneous disease in which there are perhaps different endotypes. And by endotypes, we mean different aspects of the disease that go beyond just the phenotype. Just looking at an individual classically who has type 1 diabetes, are there other features beyond phenotype that might distinguish these individuals? And you heard a lot about heterogeneity, a lot about precision medicine from the two preceding speakers. And I think that those concepts are really emerging in type 1 diabetes as well. So what are the different aspects of type 1 diabetes that can be considered heterogeneous? So what we know for sure is that there are phenotypes that differ among individuals. So individuals who are younger tend to present with more severe pancreas pathology and may have a more rapid onset of disease. We know that there are differences in ethnicity and that risk of type 1 diabetes varies with ethnicity. In terms of genetics, there are genetics associated with type 1 diabetes. And there are different sort of what we call HLA haplotypes that are associated with young versus older onset type 1 diabetes. And you could see here, those who are very young, less than 2 years, have specific HLA associations compared to those who are older than 6 years, for example. We know that there's also variability in the metabolic and pathologic aspects of this disease. For example, there's variability in pro-insulin processing in beta cells, depending on individuals that you look at. There's variability in insulitis, and that's that picture that I showed you where there's an invasion of immune cells. And there's variability in beta cell function as well. So again, we classically thought that we lose 90% or so of beta cell mass before there is onset of type 1 diabetes. So we know that there's more than that. And then the immunology itself of type 1 diabetes appear to be heterogeneous as well. So there's variability in the appearance of autoantibodies depending upon age. So individuals who are less than 2 years tend to present initially with aggressive disease and islet autoantibodies, insulin autoantibodies, whereas those who are older than 6 years tend to present with GAD autoantibodies. There is a variation in the early activation of innate immunity, and by this we mean effectively interferon signatures, and that's been shown as well, that again, early onset disease tends to have more of a signature of innate immunity. And then there's differences in T and B cell signatures in young versus older patients, and there's differences in beta cell pathology. So all of these represent the type of heterogeneous nature of type 1 diabetes that really we should begin thinking about as we think about sort of how we're going to treat these individuals. But there are many reasons why we should really care about the heterogeneity of type 1 diabetes. And that's because I think understanding the various presentations of the disease, both at the pathologic level and the phenotypic level, allows us to sort of consider the diagnosis of the disease. And we've been appreciating more recently that the disease can appear in older individuals well into their 50s and 60s that we had typically associated with type 2 diabetes. The understanding the heterogeneity can change how we treat the disease. So, for example, are there targets that we should be considering in some individuals in addition to the immune system or instead of the immune system? It can have implications for prevention of the disease. For example, when do you begin prevention? And when you do begin prevention, what are you targeting? And then finally, it can have implications with regard to our understanding of the prevalence and incidence of the disease, and in particular, how healthcare resources may be placed. So really getting to the bottom of the heterogeneity of type 1 diabetes, I think, can have very, very broad implications, as you can see. So let me give you an example. Let me give you several examples of what we used to think as classical hallmarks of the disease, but that we've learned really only in the past decade are not, in fact, universal. So we classically thought of established type 1 diabetes as characterized by the absence or near absence of beta cells. We think of insulitis as a defining pathologic feature of type 1 diabetes. And we've classically thought about the immune system as the primary defect that then triggers the death of beta cells. And I'd like to go through each of these briefly and show you that they're not as uniformly true as we thought. And because of that, we need to be rethinking exactly how the disease develops in different individuals. So let me take some examples here. This is an 18-year-old individual who had 8 years of type 1 diabetes. This was a Caucasian female who had 2 autoantibodies, IA2 and ZNT8, had undetectable C-peptide levels, and had effectively a normal BMI. And if you look at this individual's pancreas, even after 8 years of disease, you can actually identify quite a few islets that stain positive for insulin and substantially positive for insulin. And again, raising the question, is it the case that individuals with longer standing diabetes, such as this individual, really have no beta cells? There's additional evidence as well. So the medalist study, these were individuals who had type 1 diabetes more than 50 years at the Joslin Diabetes Center. When their pancreases were identified, isolated, and analyzed, there was a striking evidence of persistent beta cells in these individuals, as you could see on the left side of this diagram. And just as importantly, there was even evidence of ongoing autoimmunity as evidenced by the CD3 positive cells, but these beta cells still persist despite this ongoing immunity. So there are beta cells there, and clearly they appear to be somewhat dysfunctional because they don't produce sufficient insulin. Nevertheless, evidence that beta cells exist are also obvious when you look at C-peptide secretion in individuals with longstanding diabetes. And on the right side, you could see a study that was published in Diabetes Care that showed even when you take individuals with very, very long duration of disease, 20, 30, 40 years, you can still measure C-peptide in their circulation. And that's, again, important because it suggests that this isn't the complete absence of beta cells. It is the case that beta cells may be dysfunctional, but still present. There's new evidence as well when we look at the pancreas that there's more than just beta cells involved here. Very recently, total pancreas of these individuals have been studied, and in fact, several groups are looking at this right now. And what you're seeing here is not an atypical picture. And these are 2 individuals, one with type 1 diabetes and then a control individual who had no diabetes. And you could see that the individual with type 1 diabetes has a smaller pancreas. So the total organ size appeared to be smaller in this individual. And then when you look across individuals in autopsy studies, you can find that this is actually quite the case. And that is that if you compare to non-diabetic individuals, those with type 1 diabetes tend to have a smaller pancreas with reduced pancreas weight compared to those also with type 2 diabetes who appear to have normal pancreas weight. And if you look at these cross-sectional studies across age, the most important thing to take from this is that this doesn't appear to be a dynamic change in the size of the pancreas, simply that it may be the case that individuals with type 1 diabetes or who are susceptible to the disease just tend to have a smaller pancreas and by inference, less beta cell mass to begin with. So that may provide some level of susceptibility in these individuals above and beyond any of the other risk factors, particularly genetics and immune risk factors. So what we've learned from a lot of these studies about beta cell mass is that at onset, there are up to 50% of islets that are still positive for insulin in individuals with type 1 diabetes. And in long-standing diabetes, you can see up to 13% of islets that still remain positive for insulin. In long-standing type 1 diabetes, there's still evidence of insulin secretion as judged by C-peptide or proinsulin levels in some individuals. And some susceptible individuals who develop type 1 diabetes may begin with reduced pancreatic or beta cell mass. And again, this is not uniformity. This is just variability that exists in this disease and different than what we used to think in the past. So let's take this second case, and that is insulitis. This is the sort of classic defining feature that we had always thought of type 1 diabetes, of the immune system attacking beta cells. Insulitis was first described in 1902 in a child with recent onset type 1 diabetes. And pathologically, we define insulitis as a pancreas that has at least 15 CD45 positive cells, and these are basically immune cells per islet. These cells of CD45 cells must be present in a minimum of 3 islets. And that is all that we use to define an individual as having insulitis. So this isn't the classic picture of every islet being destroyed or invaded by these immune cells. And this insulitis is made up of a variety of cell types, but largely CD8 positive T cells. But we also see other types of T cells, CD4 positive T cells and macrophages. And then in some individuals or later in disease, we see B cells as well. So this is the insulitis that we've been classically studying in this model of type 1 diabetes called the Nod mouse. And you could see here, this was similar to the picture I showed you earlier, that these CD3 positive cells, these are T cells, beginning to attack the islet and really present throughout the islet and also surrounding the islet. But this is more classically what we see in humans when we do see insulitis, and that is that insulin staining cells are present, but you don't see that massive infiltrate that we classically thought of as insulitis in the Nod mouse. And we don't see this uniformly in every islet. And this is a good example here in a 13-year-old individual who had diabetes of 5 years duration. And insulitis was present only in about a third of insulin positive islets. And you could see the black arrows here pointing to islets that contain CD3 positive cells. But if you look at some of these other islets, here you see that there really are no CD3 positive cells invading this. So insulitis is neither uniform across individuals, nor is it really uniform among the islets of any given individual. So even when you look at the insulitis across individuals, there's quite a bit of heterogeneity. You tend to see more insulitis in younger patients compared to older patients. But even then, it's not as pervasive as we used to think, only 24% in the younger patients, 12% in the older. The infiltrate itself can be very different, again, depending on age. So the young individuals tend to contain a lot more of these B cells, or what we call CD20 high. And that seems to correlate with more aggressive loss of beta cells, whereas older individuals tend to have fewer of these CD20 cells, and they correlate with largely preservation of beta cells. But again, these individuals don't seem to secrete much insulin. And the beta cells themselves are quite heterogeneous. So when we've done single cell sequencing and mass cytometry analysis, what we've identified is that there are multiple distinct populations of beta cells. And it's been suggested that many of these beta cells, some of which are more functional than others, also have different susceptibilities to attack by the immune system. So then finally, let me go to this final aspect, and that is the concept that autoimmunity really begins to trigger the disease. So this has been sort of a classic picture where we think that beta cells begin the process because they respond to some environmental cue. And then subsequently, they undergo stress. And in that stress process, they trigger autoimmunity because their antigens that they're producing under stress conditions triggers the immune response, which then feeds back and then causes this vicious cycle of beta cell death. We have been interested in looking at perhaps whether this early phase of beta cell stress might be associated with biomarkers. And so the question really has become, is there evidence that this early stress or death in beta cells might portend risk of these individuals and their subsequent development of autoimmunity? So this is some work that we've done over the past few years, and others have done similar work as well, trying to identify biomarkers that suggest that there's an early process that beta cells themselves may be undergoing death and actually triggering autoimmunity. And so we've used this biomarker called unmethylated insulin DNA. And I'm not going to go through the details of the assay, but when cells die, they release DNA. And the thinking is that the beta cells have a unique signature on their DNA, epigenetically modified, and that's what is effectively being detected in the circulation using a very sensitive technique. And we use that technique to then identify death of beta cells. So the question is, do we see this in individuals who have no diabetes, but might be at risk for developing type 1 diabetes? And in fact, that's what we find. So we looked at individuals, control individuals. These are kids that ranged anywhere from 8 to 18 years of age. We looked at individuals with type 1 diabetes who developed the disease within a 48-hour period, so initially presented. And then we looked at the first degree relatives of these individuals. And when we looked at these different markers of DNA that represent beta cell death, what we identified was that, not surprisingly, individuals who were just diagnosed with the disease have active beta cell death, and we can detect that in their circulation. But what was really unexpected was the first degree relatives. And these are individuals who have no autoimmunity, but are at risk by virtue of being first degree relatives of these type 1 diabetic individuals, also have a signature of beta cell death that you don't see in the controls, and arguably are a little bit higher than those that we see in type 1 diabetics themselves. And so this raises the interesting question of whether, in the absence of immunity, these dying beta cells or susceptible beta cells in these individuals is actually triggering the immune response itself. It's a provocative hypothesis, but it does suggest that maybe we should be thinking about beta cells, at least in some individuals. And you could see there's quite a bit of variability in this biomarker, and that there are some individuals who have a lot of death, and there are some individuals that appear to have little or no death. So it's something to think about. In fact, those individuals who are autoantibody negative and first degree relatives also have a smaller pancreas as well. So again, these are individuals in whom autoimmunity has not developed, but they clearly have a smaller pancreas and they have dying beta cells. So again, raising the possibility that it's not the immune system that's causing beta cell death, but perhaps something within the beta cell, at least in some individuals. So we and others have been interested in what might be going on in beta cells. And the thinking is that the beta cells themselves may be under stress because of some environmental factor. And one of the stress pathways is known as endoplasmic reticulum stress, which is the endoplasmic reticulum, of course, is important in the production of insulin. And when you have environmental inflammation, such as pro-inflammatory cytokines, the ER undergoes stress and is highlighted by increased levels of proinsulin. While the cell tries to sort of mitigate that and bring it back to equilibrium, as long as that inflammatory response continues, the ER eventually fails and then the beta cell begins to die. And this is all independent of immunity, autoimmunity. And when we looked at proinsulin levels, for example, we can find that in individuals with new onset type 1, and this is within 48 hours of diagnosis, still have these very high elevated proinsulin levels, suggesting that they are under a great deal of stress. And even when they go into the honeymoon phase, there's still quite a bit of stress in these beta cells, as evidenced by high proinsulin levels. And when we looked at the TrialNet pathway to progression cohort, these are individuals who were either progressors or non-progressors, first-degree relatives, that over a 6-year period, those who developed type 1 diabetes tended to have higher proinsulin levels, again, suggestive that they may have inherent beta cell stress. And what's interesting about that is that when you look at the pancreas of these individuals, what we found was something very curious, and that is that there were cells that expressed proinsulin but did not express insulin. These are very rare findings in control donors, but we tend to see them more in these individuals with type 1 diabetes. And so it would again suggest that these cells have perhaps dedifferentiated to the point where they can produce the precursor, but can't process them any further. And perhaps this level of dysfunction might be causing or triggering autoimmunity. And this level of elevated proinsulin actually persists for long periods of time, regardless of the duration of diabetes. And you could see here, when we looked across cohorts of individuals who've had diabetes durations, regardless of their C-peptide levels, whether they were undetectable or detectable, regardless of the number of years they've had of the disease, we are still able to detect persistent proinsulin levels in these individuals. Again, suggesting that this sort of stress and dysfunction in the beta cells might be something that's inherent, even if autoimmunity weren't present. We always love to test hypotheses. And in my group, we typically go to a NOD mouse model. And I want to show you one experiment that really asks the question, if we could stop stress in the beta cell, can we stop progression of autoimmunity? And one of the key inflammatory factors that increase stress is this enzyme called 1215 LOX. And what we did was we asked the question, if we can get rid of this enzyme, but only in beta cells in these susceptible mice, can we prevent subsequent autoimmunity? So what we did was we created a fancy mouse in which we could inducibly remove just this enzyme in these mice at a very early stage of type 1 diabetes, before they get dysglycemic, but when they already have insulitis, and just knock this enzyme out in beta cells. And what did we see? A striking finding was that both males and females were strikingly protected from type 1 diabetes when we just eliminated an enzyme that promoted ER stress. And when you look at the pancreas and the islets of these mice, here's the control mouse with all of this immune infiltrate virtually absent in the knockout. So again, this raises the intriguing possibility that at least in some individuals, the heterogeneity of the disease is such that there's less autoimmunity and more beta cell stress, and the stress in the beta cells invites the autoimmunity, not the other way around. And very recently, we tested this hypothesis in individuals as well. And we blocked an ER stress cascade in individuals using a drug called imatinib. And this was a trial that was conducted at UCSF and actually several sites across the country, and we participated. And the one thing that we observed in these individuals who were recent onset diabetes, within 3 months or so of disease onset, who received the drug, those who received imatinib tended, compared to those who were placebo, tended to show a lower blood glucose levels following a mixed meal tolerance test and higher insulin area under the curve in a mixed meal tolerance test. So it suggested that even a beta cell therapy can result in at least in some individuals, in a response similar to what we see with immune therapies. And of course raises the possibility that what we really should be thinking about in individuals is perhaps combined therapies, or perhaps more beta cell therapies in certain individuals who have more of a beta cell phenotype to their type 1 diabetes, and immune therapies in those who might have a more immune phenotype to their type 1 diabetes. Okay, so this is how we now view type 1 diabetes in a slightly different perspective of that Eisenbarth diagram. And that is that we think now that individuals who might have risk for type 1 diabetes may actually begin with reduced pancreatic and beta cell mass, that there's an early stress response that occurs in the beta cells. And maybe this stress response is really the trigger that then leads to autoimmunity in the second stage, or stage 1. So we call that pre-stage 1 as beta cell stress. And that beta cell mass might be dynamic. There might be periods of time where the mass declines and then stabilizes, declines and stabilizes, and that this process may take many, many, many years before we see complete loss of mass. And that with this waxing and waning islet heterogeneity, there could be opportunities along the way to initiate therapies that both hit the beta cell and the immune response that may, in combination, do a better job of preserving beta cell mass. And then, of course, the development of type 1 diabetes can occur perhaps anywhere along the spectrum, as opposed to just at the stage where we think we lost 90% of beta cells. And the reason for that is that we think there are now a lot of dysfunctional beta cells that may not produce a lot of insulin, but may still be present. So, so we really have to be thinking about how can we wake up those cells or make them better beyond just autoimmunity. So with that, I'm just going to recognize the people in my lab who did some of the studies that I showed you, including some of those biomarker studies. And I hope this talk is at least somewhat provocative for you to think maybe about how type 1 diabetes can differ among individuals, and how perhaps our approaches to the disease should really be thinking more broadly about not just the immune system, but also beta cells. So with that, I'm happy to close out and turn it over to Peggy.
Thank you so much, Dr. Ramira. Incredibly helpful for us to understand different ways to think about beta cells in type 1 diabetes. I want to introduce our next speaker, and we will be running a little bit over, about 15 minutes, but I think that's okay and good because we're gathering great information here and sharing with our audience. I'd like to next introduce Dr. Celeste Thomas. Dr. Thomas is an adult endocrinologist, and she's an assistant professor of medicine at the University of Chicago in the section of endocrinology. Dr. Thomas is doing a number of wonderful things in the quality space, but today she's going to be talking to us a little bit about different therapeutics for individuals who have type 2 diabetes and understanding benefit of selecting therapeutic agents. Dr. Thomas, thanks for joining us.
Good morning. Thank you. Can you see my slides okay?
Yes.
Wonderful. So I'll go ahead and get started talking specifically about non-alcoholic fatty liver disease and those who also have type 2 diabetes, and thinking about precision medicine in terms of selecting the therapeutic agent that offers the greatest benefit. I have no financial interests or other disclosures. So I'd like to review briefly the epidemiology of non-alcoholic fatty liver disease as an endocrinologist, recognizing I work with the hepatologists in our multidisciplinary clinic, and think about non-alcoholic fatty liver disease as a metabolic presentation of a metabolic syndrome, in a sense, in the liver. Then reviewing the clinical spectrum of non-alcoholic fatty liver disease, considering genetic risk for Nafld, discussing the relationships between Nafld and type 2 diabetes, and of course, considering precision medicine with regard to those therapeutics. So if we look at the worldwide estimated prevalence of non-alcoholic fatty liver disease, we can look here at North America, and in red is the United States of America, showing that there is a greater than 30% prevalence of non-alcoholic fatty liver disease. We see that as well in some European countries, as well as in some Southeast Asian areas. And so one of the things we note on this particular slide, as well as it mentions in the light blue, we're seeing this frequency for the PNPLA3 genotype, which we'll see increased in North America and Mexico, but then also in those classified as Hispanic American in the United States. So let's think back to, so what this group did was they looked back at the prevalence of non-alcoholic fatty liver disease in the United States using the National Health and Nutrition Examination Survey, also called NHANES survey, in 1988 and 1994, looking at chronic liver disease and what were the causes of chronic liver disease, and looking at the change over time for the causes of chronic liver disease. And so if we were to start with chronic hepatitis C, and seeing that the chronic hepatitis C as a relative contribution to chronic liver disease has decreased over time. And if we were to look at alcohol-related liver disease, and we remember our confidence intervals here, we recognize that alcohol-related liver disease has been stable over time, as has chronic liver disease attributed to chronic hepatitis B. What we see increasing in relative percentage or relative prevalence for chronic liver disease is non-alcoholic fatty liver disease. So increasing in significant ways to contributing to chronic liver disease. One of the things that also happened over this time course, if we think about the CDC images of what obesity looks like in the United States of America and what type 2 diabetes prevalence looks like, we can imagine that type 2 diabetes and obesity are going to potentially be contributing to this increased relative prevalence of non-alcoholic fatty liver disease. And the authors actually looked at that. So they looked at a multivariable regression analysis to examine the contribution of obesity and type 2 diabetes. And so those two were actually strong predictors with those odds ratio of contributing to the increase in non-alcoholic fatty liver disease, with obesity significantly contributing with an odds ratio of 10.4 and type 2 diabetes 3.7. And so then we think about the presence of comorbidities amongst this population at the 2013 to 2016, and whether or not if there was obesity present, type 2 diabetes present, or neither. And for those who did not, according to NHANES data, where obesity is classified as a BMI greater than 30, and in NHANES data, we actually diagnose diabetes, not classifying it as type 2, but diagnosing diabetes based on either it being reported, the medications being reported, or fasting glucose levels being elevated as a way to determine undiagnosed diabetes. And so neither obesity nor type 2 diabetes present, you see that there's a much lower risk of non-alcoholic fatty liver disease. But with both type 2 diabetes and obesity in this particular analysis, the significant risk percentage with non-alcoholic fatty liver disease. Other studies have shown that both type 2 diabetes and obesity having a prevalence of about 55% or so of non-alcoholic fatty liver disease. So then looking at non-alcoholic fatty liver disease and non-alcoholic steatohepatitis and what that spectrum looks like, we then recognize that non-alcoholic steatohepatitis is the second most common indication for liver transplantation in the United States, but it's actually the leading cause of liver transplantation in women in the United States. And it also contributes to the burden of hepatocellular carcinoma. So we're thinking about increased need for transplantation, and sometimes that transplantation is due to decompensated liver disease, but other times it's due to the hepatocellular carcinoma. So if we go back and think about that 30% of the population having non-alcoholic fatty liver disease and think about the progression, 10% of those with non-alcoholic fatty liver disease will develop non-alcoholic steatohepatitis. And then 25% of those will develop cirrhosis. And somewhere between 10 to 25% of those with cirrhosis will develop a primary liver malignancy. So going back to that clinical spectrum, we have that healthy liver with fewer than 5% fat, and then we see small droplets of fat, and then non-alcoholic fatty liver disease, potentially causing some inflammation, where we see these hepatocytes, it's determined language of ballooning hepatocytes, large droplets of fat. What's important here is that when there's non-alcoholic steatohepatitis, that's actually reversible. And of course, non-alcoholic fatty liver disease is reversible. When there's significant scarring in the development of cirrhosis, then that's less reversible. And so that's why there's been a call to action to understand who has non-alcoholic steatohepatitis and make sure that we're reversing that. So when we think about genetic risk, we go back to that initial slide where we saw that increase in this PNPLA3, or the prevalence of that PNPLA3. That's one of 5 variants, at least 5 variants in different genes that have been identified. And that's the one with the most robust relationship with non-alcoholic fatty liver disease. So some of the other mechanisms of pathophysiology, of course, are insulin resistance, recognizing that an insulin resistance is going to result in increased lipolysis and the availability of free fatty acids. And at the muscle cell, right, that's where we're going to see reduced glucose uptake with that insulin resistance. And so with that excess accumulation of fatty acids, we see lipotoxicity. We just referred to that ER stress, and we also see that, lipotoxicity resulting in oxidant stress and inflammasome activation. And so this inflammation through multiple sequential and parallel triggers are contributing to the steatohepatitis. And then there's this role of the gut microbiota, also associated with increased inflammation, but also decreased GLP-1, and overall really a complex pathophysiology here, like much of what is happening in the metabolic syndromes. So when we think about the relationship between non-alcoholic fatty liver disease and type 2 diabetes, if we start here thinking about patients who only have non-alcoholic fatty liver disease, and so in our multidisciplinary clinic, we have patients who do not carry a diagnosis of type 2 diabetes, but come in with non-alcoholic fatty liver disease as the reason for consultation, noticing that there is a twofold increase in risk for the development of type 2 diabetes. And we see evidence of insulin resistance on physical exam, as well as hyperinsulinemia. And then recognizing that those who have type 2 diabetes are at increased risk for non-alcoholic fatty liver disease, but especially increased risk for more clinically significant non-alcoholic fatty liver with liver fibrosis. And so we'll see a 2 to 6-fold increase in risk for progression across that spectrum of non-alcoholic fatty liver. And then those with that steatohepatitis, of course, we talked about that increased risk for hepatocellular carcinoma. But it's important to note that these individuals are at significant risk for cardiovascular disease. And so when we think about tailoring our therapy for those with both non-alcoholic fatty liver disease and type 2 diabetes, remembering that cardiovascular disease is a significant risk factor will be important. So Dr. Phillipson went through kind of thinking about these subtypes, and it's important to to recognize, I did list kind of the countries here, a homogeneous population where we saw these initial subtypes, thinking about type 2 diabetes and the severe insulin deficient diabetes, the severe insulin resistant diabetes, and they even noted, that there was insulin resistance, increased risk of nephropathy, and also fatty liver, the mild obesity-related diabetes, and then that mild age-related diabetes with later onset and lower risk of complications. So a group tried to recreate that in China as well as in the US, looking at 2,300 or so adults with diabetes. And in the China National Diabetes and Metabolic Disorders Study, they were looking at newly diagnosed. Now, we just referenced the NHANES study. So there's 685 adults with diabetes from the NHANES survey as well. But remembering that, these things change over time. And so this analysis, of course, is going to be limited by the time of diagnosis. But they were able to kind of describe similar clusters of type 2 diabetes. And so then we're going to think about, using that to determine what the therapy should be for those with type 2 diabetes and non-alcoholic fatty liver. And so that's where we are when it comes to, the Chung et al. Paper, thinking about precision therapeutics to tailor the therapy using information about that unique biology, that environment to treat the disease. So for non-alcoholic fatty liver disease, there are non-pharmacologic interventions, and there are no FDA-approved medicines for NASH itself, but we're talking about type 2 diabetes and non-alcoholic fatty liver. And so we recommend the Mediterranean diet. I'd love to have time to review some of the interesting studies on coffee, olive oil, also exercise, cardiovascular and resistance training, restorative sleep. There's some good evidence about, avoiding fructose-enriched beverages and how the body is metabolizing fructose and how that contributes to fatty liver. Of course, avoiding excess alcohol and the diagnosis of non-alcoholic fatty liver as we have to exclude those who do consume excess alcohol in order to make that diagnosis. I grayed out the weight loss here because we talked about that genetic risk. And, we talk about lean type 2 diabetes, and there can also be, especially in those that who have some of those genotypes, there can be a normal weight with fatty liver disease. So you've seen this slide as well. So there's some continuity here, and I just changed this targeting diabetes therapy to comorbid non-alcoholic fatty liver disease. And we'll think about, we talked about that increased lipolysis as one of the big drivers and reduced glucose uptake. And so when you think about the adipocyte and its contribution to non-alcoholic fatty liver, we've got to circle the thiazolidine diones, even though I think they're misspelled here. And so then we'll think about the thiazolidine diones in type 2 diabetes with non-alcoholic fatty liver disease. So they bind to the PPAR gamma, or the peroxisome proliferator activated receptor, and improve insulin sensitivity in the liver, skeletal muscle, and adipose tissue, also increasing the plasma adiponectin levels and decreasing those pro-inflammatory cytokines. And so there have been several studies, and so if I just kind of review the meta-analysis here, that showed significant improvements in steatosis. And so that was, specified with the ballooning, and also a decrease in the combined mean kind of necroinflammation score over placebo. But there was no significant improvements in fibrosis. And we talked about that tailoring and who are those non-responders when it comes to precision medicine, with about 50% of subjects being classified as non-responders. And so despite the improvement, there was progression of any fibrosis actually continued in both groups, but it was reduced in the pioglitazone group. This was lower in the pliazidone group compared to the placebo. So then we return to kind of targeting diabetes therapy to the comorbid Nafld and think about increased hepatic gluconeogenesis. Is there a role for metformin? And so again, a meta-analysis looked at data from 9 studies, so this only included about 417 participants, on the use of metformin for non-alcoholic fatty liver, with the primary outcome being a histological response to therapy, again, thinking about that steatosis, inflammation, that hepatocellular ballooning, with no significant difference was seen in any of the variables between metformin and diet and exercise alone. And so these studies were actually done in those with diabetes and in those without diabetes, and we did not see an improvement with metformin. And so just looking at the time here, looking at glucagon-like peptide 1 receptor agonists in type 2 diabetes and non-alcoholic fatty liver disease, we recall that GLP-1 is secreted upon ingestion of food. The beta cells, there's going to be enhanced glucose-dependent insulin secretion, delayed gastric emptying. And then we have this paracrine effect with the activity of the beta cell having its impact on the alpha cell and decreasing glucose-dependent postprandial glucagon secretion. And so with the liver, we're going to see glucagon with reduced hepatic glucose output. And then the GLP-1 also promoting satiety and reducing appetite. So the LEAN study, so this was liraglutide safety and efficacy in patients with non-alcoholic steatohepatitis. This was a proof of concept, multi-center, randomized, double-blind, placebo-controlled study that looked at just 52 patients. And they wanted to look at the impact on fatty liver without the confounder of improving diabetes control. So they selected those who were at their targets, A1Cs, and assigned half to liraglutide and half to placebo, and gave the same diet, exercise, and weight loss recommendations, and then actually performed biopsy before and after, with 39% of those in a liraglutide group having resolution of steatohepatitis versus 9% in the placebo group. But they also saw changes in A1C, weight, BMI, and HDL. And so it was hard to say if it was really the liraglutide itself or was it having an impact on weight, recognizing that weight loss itself is a treatment for non-alcoholic steatohepatitis. So then there was a more recent study looking at semaglutide, and this is subcutaneous semaglutide administered daily. And so if I just go through kind of table 1 here with the semaglutide, the 0.1 milligram group, the 0.2 milligram group, and the 0.4 milligram group. And then recognizing that about 50% of the participants or the subjects had diabetes across the groups. But they all, those who did have diabetes, the idea again was to not have markedly elevated A1C, so that we're looking at the impact not just on achieving glucose control and how that in and of itself will improve NASH, but looking at the medicine. And so we can look at the resolution of NASH. Now, this was not done with biopsy. This was looking at MR imaging to show the percentage of patients with decrease in NASH and with no worsening of liver fibrosis. And so we were able to see that this was significant with all of the doses of semaglutide, but most significant with the highest dose, the 0.4 milligrams daily. But when we look at the actual improvement in liver fibrosis, we see that there was no change. And so we're coming to a point where we can see that steatohepatitis, but not a change in the fibrosis. So then this meta-analysis looks, so this is a forest plot, a meta-analysis that's looking at pooled estimates of the effect of different GLP-1 receptor agonists on liver fat, again, so MR imaging of the liver. And so the blue squares are showing the weighted mean difference. Oh, excuse me. The blue square is showing the weighted mean difference, and then the green diamond, the pooled effect, showing that we're favoring GLP-1 receptor agonists for non-alcoholic steatohepatitis. Now I'll briefly review kind of the renal reabsorption of glucose and recognizing that in the proximal tubule, the sodium glucose cotransporter 2 reabsorbs most of the filtered glucose. And when we look at this in glucose cotransporter 2 inhibitors, we see that we are able to increase glucose excretion and reduce blood glucose levels, resulting from less glucose reabsorption. And so what's the effect of these agents on non-alcoholic fatty liver disease in people with type 2 diabetes? So in a randomized placebo-controlled trial of 84 subjects with type 2 diabetes and non-alcoholic fatty liver, 10 milligrams of dapagliflozin or 4 grams of omega-3 or combination versus placebo. Again, using MR imaging and the proton density fat fraction, all active treatments reduced liver proton density fat fraction from the baseline. And so when we think about what's happening with SGLT2 inhibition and non-alcoholic fatty liver, there's a decrease in the lipogenesis. So the SGLT2 inhibitor is going to decrease lipogenesis in the liver and the adipocyte, stimulating ketogenesis and gluconeogenesis, which is going to reduce and result in reduced fat accumulation in the liver. And then there's also increased adiponectin, which is going to increase insulin sensitivity. So thinking about precision medicine, therapeutics for non-alcoholic fatty liver disease and type 2 diabetes. So this review article just looked at the data, and for these phase 2 placebo-controlled or head-to-head trials testing the efficacy of these agents. And so when we think about liver enzymes, all of them were associated with improved liver enzymes. They actually include DPP4 inhibitors here, which have no effect on liver fat. So I did exclude those from our discussion, but we see improvement in some studies in the liver fat from metformin. We do see improvement in the thiazolidine ziones, improvement in the GLP-1 receptor agonists, and then with the SGLT2 inhibitors, recognizing that this is currently being studied in phase 3 trials. And so we're still collecting data on those. And so coming back to precision therapeutics for non-alcoholic fatty liver disease and selecting therapeutic agents with a greater benefit, we would want to tailor our therapy. And so for the patients that I see in our multidisciplinary fatty liver clinic, we select GLP-1 receptor agonists, SGLT2 inhibitors, and sometimes the thiazolidine diones. We see a lot of patients with rheumatologic conditions and risk for fracture, and for those, I don't select the TZDs. Also not for those with progressive type 2 diabetes and any previous hospitalization for heart failure. And so thinking about overweight and obesity versus chronic kidney disease and whether or not there's cardiovascular disease to help select those agents. Now in there.
Thank you so much, Dr. Thomas. We truly appreciate it. And then last but not least, we want to ensure that we have, actually, I want to have you answer one question. I think this is valuable. Were there any studies on insulin similar to studies of GLP-1 and SGLT2 meds versus NASH? And
so any studies on insulin, using insulin?
Fatty liver disease.
I
yes.
have not seen any studies looking at insulin for fatty liver disease. As a matter of fact, my practice is to reduce insulin use because of the risk for weight gain in those with type 2 diabetes on insulin.
Sure. I appreciate that. Thank you. Thanks again, Dr. Thomas. Fantastic information on non-alcoholic fatty liver disease and type 2 diabetes. And then finally, we're going to have Laura Dickens talk to us. Dr. Dickens is an endocrinologist at the University of Chicago in the section of endocrinology. And she's going to share with us today precision medicine focusing on diabetes and pregnancy. This has become a specialty of Dr. Dickens, and we're grateful, as are many expectant mothers, that she's doing this work. Thanks, Dr. Dickens, and we look forward to hearing your presentation.
All right, thanks so much, Peggy, and thank you everybody for hanging in to the end. My name is Laura Dickens, and as Peggy said, I'm excited to present to you today about the application of precision medicine to diabetes and pregnancy. Here we go. All right, so I have no disclosures. All right, and I'll start just by reviewing the objectives of my talk. So first, I'm going to review some background about diabetes and pregnancy, including prevalence, complication, and some fundamentals of treatment. This is then going to lead into a discussion about the heterogeneity of diabetes and pregnancy. And then we're going to discuss the application of precision medicine to diabetes and pregnancy using some examples of genotype and phenotype-based approaches. To start, here we have a few statistics. So diabetes is one of the most common medical complications of pregnancy. In the United States, 1 to 2% of pregnant women will have type 1 or type 2 diabetes, and 6 to 9% of pregnant women will be diagnosed with gestational diabetes. A recent study was published in JAMA, which found that between 2011 and 2019, the rates of gestational diabetes increased among all race and ethnicity subgroups and across all age groups. So we expect to see these numbers continue to increase. In addition to type 1, type 2, and gestational diabetes, we'll be talking some about a form of monogenic diabetes, GCK-MODY. So I'll provide some more background shortly, but I would like to note that 1% or more of women diagnosed with gestational diabetes will actually have GCK. So as we'll talk about, the management of GCK is different than other forms of diabetes and pregnancy, and an accurate diagnosis is important. All right, so this slide reviews the maternal and fetal complications associated with diabetes and pregnancy. We can begin with fetal complications, which are listed on the left. With pre-existing diabetes, hyperglycemia in early pregnancy increases risk for miscarriage and congenital anomalies, including heart defects and brain and spinal cord abnormalities. In later pregnancy, hyperglycemia increases risk for accelerated fetal growth and associated delivery complications. There are also long-term consequences for offspring, which can include higher rates of obesity and later type 2 diabetes. The right side of this slide lists maternal complications of diabetes and pregnancy, which can include a higher risk for preeclampsia and need for cesarean birth. For pre-existing diabetes, we can see a worsening of retinopathy. For gestational diabetes, there's a significantly increased risk for subsequent development of type 2 diabetes. On a more positive note, we have good evidence that treatment of diabetes and pregnancy reduces these complications, as well as neonatal outcomes, including stillbirth, macrosomia, and shoulder dystocia. There are several core principles of diabetes management during pregnancy, which are outlined here. First, glycemic targets are strict and aim to achieve blood sugars as near normal as possible to reduce the risk of complications. Frequent monitoring of blood glucose is recommended by finger stick or continuous glucose monitor to adjust diet and medications and assess diabetes control. Dietary modifications will play a critical role, particularly for pre-existing type 2 diabetes and gestational diabetes, when women are advised to moderate carb intake and limit concentrated sweets. Physical activity and appropriate weight gain are additional key management principles. If these lifestyle measures are insufficient to achieve glycemic targets, then medications and primarily insulin will be indicated. From an obstetric perspective, additional testing is recommended to evaluate for complications in pregnancies affected by diabetes. This can include additional ultrasounds to evaluate for congenital malformations or accelerated fetal growth. And there are protocols to assess fetal well-being, such as weekly biophysical profiles in the 3rd trimester. The complications and management principles I just reviewed are often applied to all pregnancies affected by diabetes, regardless of the type of diabetes or other clinical characteristics that may impact treatment response or clinical outcome. To put it simply, a one-size-fits-all approach is often applied to a group that is anything but. Within these different types of diabetes, research has begun to illuminate genotypic and phenotypic variations, which impact the risk for complications and ultimately may inform best management strategies. So this leads us to the question, rather than using this one-size-fits-all approach, can we use our expanding knowledge of the genotypic and phenotypic variation in diabetes and pregnancy to better understand a woman's risk for adverse outcomes, and develop more targeted management strategies. All right, so I'm going to begin by discussing an example of genotype-based approach to diabetes and pregnancy using the case of GCK Modi. These basics may be familiar to some, but as a refresher, GCK Modi is caused by an autosomal dominant heterozygous inactivating GCK gene mutation. So GCK is thought to be the glucose sensor of the pancreatic beta cell, and mutations in this gene cause fasting blood sugar to be elevated, but it's regulated at this higher level. The prevalence of GCK Modi is estimated about 1 in 1,000, but it's often undiagnosed or can be misdiagnosed as type 1 or 2 or gestational diabetes. Affected patients have mild asymptomatic fasting hyperglycemia with the blood sugar and A1C ranges listed here. High blood sugar is present at birth and does rise slightly with age. The hyperglycemia is often incidentally noted on screening tests or can be first detected during pregnancy, and then the diagnosis is confirmed with genetic testing. This table outlines the key features that differentiate GCK Modi from type 1, type 2, and gestational diabetes. People with GCK can be differentiated from those with type 1 diabetes by less severe hyperglycemia, negative pancreatic autoantibodies, and intact C-peptide. Compared to patients with type 2 diabetes, those with GCK Modi have lower rates of obesity and less severe hyperglycemia. And as I mentioned, GCK can be misdiagnosed as GDM. However, with GCK, we'd expect that mild fasting hyperglycemia to persist after delivery, whereas many cases of gestational diabetes return to normal glycemia postpartum, albeit with that increased risk over the lifetime for type 2 diabetes. A key feature to understand about GCK is that treatment is typically unnecessary because complications of hyperglycemia do not occur with GCK Modi in the way that they do with other forms of diabetes. This chart shows that kidney dysfunction, neuropathy, and cardiovascular disease occur at low rates in GCK Modi, similar to controls, and at significantly lower rates than patients with type 2 diabetes. The literature has observed that patients with GCK do have a higher rate of background retinopathy. However, it's typically mild, and in the study mentioned here, no patients with GCK and retinopathy required laser therapy. All right, so furthermore, treatment with glucose lowering therapy is typically ineffective. This was a study of 800 patients with GCK in the UK. And here they observed no difference in A1C between patients on treatment, either oral medications or insulin at the time they were diagnosed compared to those on no medication. And then when treatment was stopped after a genetic diagnosis was made, there was no significant change in A1C. So in summary, GCK causes stable, mild fasting hyperglycemia, which does not lead to long-term complications, and therefore treatment's generally unnecessary. The one exceptional circumstance where management may differ is GCK during pregnancy. So in pregnancy, the outcomes, and more specifically birth weight, will depend on whether the baby inherits mother's GCK mutation. So that's a 50-50 chance for this autosomal dominant condition. If the baby inherits mom's GCK mutation, mild maternal hyperglycemia is sensed to be normal. So growth will proceed normally and birth weight is normal. No treatment is needed to lower maternal blood sugar in this case. If the baby does not inherit the maternal GCK mutation, the baby senses that mild maternal hyperglycemia to be abnormal, and there's risk for fetal overgrowth and those associated complications. In that case, insulin treatment is recommended to lower blood sugar and avoid fetal overgrowth. The graph here illustrates the observed difference in birth weight based on GCK mutation status. So the black bar shows the case where mother and baby both have the GCK mutation and growth is normal with a median birth weight in the 47th percentile. The white bar on the left shows the circumstance where mother has the GCK mutation, but baby does not inherit it. And here the median birth weight increases to the 85th percentile. On average, GCK unaffected fetuses, so those who do not inherit the mutation, will weigh about 700 grams or 1.5 pounds more than fetuses who do inherit the mutation. So based on this data, it's been recommended that pregnant women with GCK should only be treated with insulin if the fetus has not inherited the GCK mutation and has this risk for fetal overgrowth. In addition to the concern about macrosomia in cases where the fetus does not inherit that GCK mutation, we do have some concern about lower birth weight or growth restriction in cases where the fetus does inherit the GCK mutation, but insulin is used. So in other words, the blood sugar is lowered below the fetus's physiologic set point. So here's data from a study we performed as a survey of women in the monogenic diabetes registry. This surveyed 54 women with known GCK and collected data about 128 pregnancies. Here we observed that in pregnancies where the infant inherited GCK, but mother was treated with insulin, there were lower birth weights and an earlier gestational age at delivery, which suggested an increased medical intervention in these pregnancies. We also observed frequent severe hypoglycemia in pregnancies where women with GCK were treated with insulin, which highlights a potential harm of insulin treatment, particularly in cases where it's not necessary. All right, so how can we know if baby inherited the mutation in order to determine the optimal treatment? Genetic testing of the fetus is not recommended unless indicated for other reasons, and this is due to risks of miscarriage from CVS or amniocentesis. So instead, the recommendation is serial ultrasound monitoring of fetal growth to infer the fetal genotype. And this figure illustrates that approach where growth scans are recommended beginning at 26 weeks gestation. If fetal abdominal circumference surpasses 75th percentile, then insulin treatment is initiated. The strategy of using ultrasound monitoring of fetal growth has its limitations, however. So by the time accelerated fetal growth is appreciated on ultrasound, it may be difficult to alter the course and slow fetal growth, even if you start insulin at that point. So there have been some recent advances in the study of more precise methods to determine fetal GCK status using cell-free DNA testing. This technology isolates cell-free DNA of fetal origin within maternal circulation, which can then be tested for different genetic abnormalities. It's commonly used currently for Down syndrome and other chromosomal abnormalities. So testing may be more or less difficult depending on the type of gene mutation. New mutations and those that are paternally inherited are typically more straightforward since there is not overlap with maternal DNA. However, maternally inherited mutations can be more difficult to diagnose due to the expected presence of the maternal mutation in circulation. Advances in this cell-free DNA technology have allowed successful prenatal diagnosis of GCK mutation status. So this was a study in the UK where they performed cell-free DNA testing on 38 pregnant women who had either GCK or HNF4 alpha MODY. And in 33 cases, the baby's MODY status was correctly determined. There were 5 cases where they couldn't make a determination, but it sounds like the major issue there was that a follow-up sample was not available, which may have led to an accurate diagnosis. So for this analysis, they used a technology called droplet digital PCR, which quantified reference and variant alleles, and then based on the fetal fraction, performed statistical analysis to determine the probability for fetal genotype, and it was successful. While this technology is still in the research phase and not widely available, it's encouraging to know that these results have been replicated by other groups with similar success to prove the concept that prenatal diagnosis of GCK mutation status by cell-free DNA is possible. All right, so GCK is a pretty dramatic example of how precision medicine can be applied for diabetes in pregnancy, and the fetal genotype will directly determine the appropriate treatment. This accounts for a small proportion of diabetes in pregnancy. Of course, as I've said, it's about 1% of gestational diabetes. So I'd like to spend the next few minutes discussing how we can apply precision medicine to the larger population of gestational diabetes, and here using a phenotype-based approach. All right, so let's begin by discussing approaches to characterize the different subtypes of gestational diabetes. So historical studies have delineated between lean and obese GDM, but a more recent study by Poe et al. Used a different and more physiologic basis for separating the different subtypes of gestational diabetes. So here they examined a cohort of about 800 pregnant women, of whom 67 developed gestational diabetes based on the IAD-PS2 criteria. Insulin and glucose levels during oral glucose tolerance tests were used to estimate insulin secretion, sensitivity, and resistance. The GDM subtypes were then defined by comparing these measures of secretion and sensitivity to women with normal glucose tolerance. So they identified 3 different subtypes here. One was GDM with an insulin secretion defect. The next was GDM with an insulin sensitivity defect, or sort of a classic insulin resistance picture. And then the third was GDM with both defects, which they called the mixed subtype. This study then compared clinical characteristics, adipokines, and pregnancy outcomes between the different GDM subtypes. So this chart compares the characteristics that were observed in the different subtypes. So starting with BMI, they found that the group, the GDM sensitivity group, so the insulin resistant patients had higher BMI, whereas the GDM secretion and GDM mixed groups actually had similar BMIs to those with normal glucose tolerance. For fasting blood sugar, they observed that fasting blood sugar in the late second trimester was elevated in the GDM sensitivity, so the insulin resistant group and the mixed group, compared to those in the normal glucose tolerance group. The fasting blood sugar in late second trimester for the GDM secretion group was actually similar to women with normal glucose tolerance. Interestingly, the treatment was similar, so between the subgroups, a similar proportion of patients were requiring insulin treatment. As far as the fetal and neonatal outcomes, women in the GDM sensitivity, so the insulin resistant group, had infants with greater birth weights and a greater risk of GDM associated adverse outcomes, which I'll talk about on the next slide, in comparison to women with normal glucose tolerance. Women with GDM and secretion defects, or the GDM mixed groups, were actually similar to those with normal glucose tolerance in terms of outcomes. So there was not an increased risk for those adverse pregnancy outcomes in those two groups. And the difference between these groups in pregnancy outcomes did persist after adjusting for BMI. So this chart compares the clinical characteristics and pregnancy outcomes between those different subtypes. And I apologize, I think the bottom of the chart looks like it actually got cut off here, but I highlighted a couple of the key measures. First was just the N for each of the groups, which showed that about half, or 50% of the women with GDM had sensitivity defects, so they did fit that classic insulin resistance picture. The BMI was significantly higher in this group, with the sensitivity defect at about 30 compared to 22 to 25 in the other groups. And the part that's cut off at the bottom was showing that there was an increased risk for large for gestational age, C-section, and a composite for any adverse outcome for women that had the GDM with sensitivity defect, or the insulin resistant patients. So the conclusion from this study was that women with typical insulin resistance picture, so the GDM sensitivity group, had larger infants and greater risk for GDM related complications compared to those with insulin secretion or mixed defects. All right, and there have been some subsequent studies in different cohorts that have confirmed the findings of this initial study. It can get a little bit confusing because the subtypes are defined a little bit differently in the different literature, but I wanted to talk through one additional study, which was a multi-center prospective cohort study in Belgium. And here they stratified about 1,800 women according to insulin resistance based on their 75-gram oral glucose tolerance test at 24 to 28 weeks. And here, gestational diabetes was diagnosed in about 12%, or over 200 patients, based on the WHO criteria. And here they classified insulin resistance based on a calculation index that was below the 50th percentile of women with normal glucose tolerance, so a little bit more broad definition. And in this study, more than 80% of the women were classified as insulin resistant. So it was either insulin resistant or insulin sensitive, with no mixed group included in this study. Looking at the subgroup characteristics, so when compared to women with normal glucose tolerance or insulin sensitive women, the insulin resistant group with gestational diabetes had significantly higher BMIs, systolic blood pressures, fasting blood sugars, total and LDL cholesterols. And looking at outcomes, again, compared with normal glucose tolerance, women with GDM and high insulin resistance had higher rates of preterm delivery, labor induction, C-section, neonatal hypoglycemia, and neonatal intensive care unit admissions. The insulin sensitive group of women with gestational diabetes had similar pregnancy outcomes to the women with normal glucose tolerance. Also worth noting in this study, the need for insulin treatment during pregnancy and the rate of glucose intolerance in the early postpartum period were not different among these different subtypes. All right, so these studies have generated some important conclusions and also raised some compelling questions for further investigation. First, they demonstrate that using readily available glycemic data from oral glucose tolerance tests allow us to classify women with GDM into subtypes based on degree of insulin resistance. And they've also shown that women with GDM who have predominant insulin resistance will have a more adverse metabolic profile and a greater risk of GDM-related complications. Whereas interestingly, there's another subgroup that does not seem to have an increased risk of adverse outcomes compared to those with normal glucose tolerance. So now that we understand and to some degree can differentiate the different subtypes of gestational diabetes, what strategies with precision medicine could we apply to improve care and outcomes? So the idea of targeting treatment for GDM to the populations most at risk for adverse outcomes is not novel. There have been prior studies which looked at specifically the use of ultrasound-guided management of GDM, whereby patients with gestational diabetes demonstrating accelerated fetal growth on ultrasound are more targeted to receive insulin treatment. So this is a meta-analysis which looked at 2 randomized controlled trials comparing ultrasound-guided management of gestational diabetes versus conventional management. And here they found that this ultrasound-guided management could decrease rates of large for gestational age and macrosomia, but it came at a cost. So the improvement in birth weights, in order to achieve that, they needed to treat more women with insulin. 58% more women required insulin treatment in that strategy. The number of women with gestational diabetes needed to treat to prevent an additional abnormal birth weight was about 10. So a number needed to treat of 10 to improve those birth weight outcomes. We certainly need more research in this area. The studies are limited, owing, as evident by this meta-analysis, just including 2, and the patients included are certainly heterogeneous, but does give some promising evidence for a potential strategy. On this last slide, I'm just going to introduce a couple of ongoing clinical trials which are looking into this further. So these are studies which are examining individualized treatment for gestational diabetes based on subtypes. So the one listed first is looking at the effects of different pharmacologic treatments in the different GDM subtypes. And the second is looking at the effect of different nutrients on glycemic profiles in the different GDM subtypes. So I do think that we're going to see some more exciting advances in this field in the coming years, which may revolutionize our current treatment strategies for GDM. So stay tuned for more developments in this, this exciting area of research. And I'm happy to answer any questions if we have a couple of minutes. I know we've gotten past on time.
Thank you so much, Dr. Dickens. This was a fantastic presentation. There is some question about how we can get more of this information to midwives and to OBGYNs and even maternal fetal medicine. What type of outreach do you currently do, or how do you partner with maternal fetal medicine and OBGYNs internally and externally at the medical center?
Yeah, great question. So here at the University of Chicago, I actually run a multidisciplinary clinic together with our maternal fetal medicine group. So we have a combined clinic where we see women with diabetes and pregnancy in the same physical space and combine the resources of MFM, specialized ultrasound, as well as our registered dietitians and diabetes educators. And I think these programs are becoming more common across the country, recognizing that this is a complex condition that requires, a lot of specialist interaction, as well as many frequent appointments for patients. So as much as we can streamline that process, I think it will help outcomes. So that's our care model here at the university. And then we've also been doing more sort of community outreach. We did a recent webinar sort of for a patient and more general audience about gestational diabetes, and are trying to spread the word in that way, but still certainly a lot of room for getting this information out and helping to improve care across different institutions and geographic areas.
Great. Thanks so much, Dr. Dickens. This concludes our program today. We are honored and grateful to have all of our attendees here. And we thank our speakers again, and certainly our attendees. If you'd like to share this information or share some of these slides or presentations, we will have this available on our CME website. And I will be sure that all attendees who have joined us today have that information to share with colleagues and other healthcare professionals if they want to learn and weren't able to join us today. So from all of us at the University of Chicago Kovler Diabetes Center, thank you so much and have a great day.